So here's an interesting case. This is a patient of mine that presented with the symptoms of right hand ischemia, like numbness in the fingers and weakness in the hand. He had this percutaneous fistula done about 2 years ago. So here is the brachial artery. Here's the anastomosis of the radial artery to the perforating vein. This would be the perforating vein. And you see the fistula is very well developed. So we did not, this is done with a small 3 French catheter. It's just the inner portion of the micropuncture sheath. And you can see that the arterial system is fine. You can actually see the ulnar artery widely patent going all the way to the hand. Obviously, I'm injecting through a small catheter, so the images are not great. Then we did a central venogram, and the central venogram shows complete occlusion of the right brachiocephalic vein. So we use a snare to grab the wire, and we went through the cephalic vein with a catheter to be able to recanalize that vein. Once we recanalize, we're able to grab the wire and externalize to the groin. I used a shuttle sheet just to be able to inject and actually visualize the IVC and see what segments of the IVC are actually patent. And then we wanted to be very precise here because we didn't want to go over the first rib, which is right here. And we also did not want to occlude the left brachiocephalic vein, which is this vein coming here. So I decided to use 2 stents there, 2 11 by 29 VBX stents. So we deployed the first one here. You can see the waist. And then I'll deploy the second one extending to the left brachiocephalic vein without blocking the left brachiocephalic vein. We still had a waist that we couldn't dilate with the regular VBX balloon. So we then used a Dorado balloon. This is a 12 millimeter Dorado balloon. Patient's having some pain, you can see that. It's under moderate sedation. And this is the final pictures. It looks perfect. We don't feel like it needs to be dilated again. The patient improved immediately afterwards and the symptoms completely disappeared. This proves that the patient did not have an arterial problem, but the problem was actually high venous pressure. So even though the patient had ischemic symptoms, the problem was not an arterial problem or even Steele syndrome, but the problem was actually that the venous pressure was so high that was compromising what's called the perfusion pressure, which is the difference between the systolic pressure and the venous pressure. We can see this in the brain, and we can also see this in the arm in patients with dialysis access problems.